So tonight's session is the first in the series, and it's going to be co-led by Dr. Elmore and Dr. Tony Back. Is your doctor really hearing you? Dr. Elmore is a professor in general and internal medicine here at the UW School of Medicine, and also adjunct professor of epidemiology. She's section head for general internal medicine at Harborview. She got her MD degree at Stanford and did her residency in internal medicine at Yale, where she also received advanced training in epidemiology. Her interests include accuracy of cancer screening and diagnostic testing and evaluation of new technologies. She's co-authored a textbook on epidemiology, biostatistics, and preventive medicine. And she still enjoys, despite all this scientific work, seeing patients as a primary care internist and teaching clinical medicine to students and residents. Dr. Back is a professor of medicine here in the Division of Oncology. He's adjunct professor in medical history and ethics and director of cancer communication here at the Seattle Cancer Care Alliance. He's a board-certified medical oncologist who practices medicine at the Seattle Cancer Care Alliance and at UW Medical Center's liver tumor clinic, where he treats patients with colorectal, liver, pancreatic, and stomach cancer. He teaches new physicians how to communicate grave prognoses to patients. He got his MD degree from this small school on the East Coast and completed his residency here at the University of Washington. He was a postdoctoral fellow in oncology at UW and at the Fred Hutchinson Cancer Research Center. Dr. Back's research interests include palliative care and patient-physician communication. He was a faculty scholar on the Project on Death in America and an investigator on NIH-funded studies of doctor-patient communication about malignancies, use of therapies, and hope. He says that he was motivated to study medicine in part by the death of his mother when he was a college sophomore. I will now turn it over to Dr. Elmore, and thank you all for attending.
So this is my first question for you. On average, how much time does a patient speak before a physician interrupts? And I give you ranges from A, 5 minutes, B, 3.07 minutes, C, 1.07 minutes, D, 47 seconds, and E, 18 seconds. So please enter your rating. This is not a test. You will not be graded. And this shows you your guesses. And I find this interesting in that this shows we have a very educated group here. And I think you probably see doctors that talk really fast and are really busy, and many of you said 18 seconds. You're right. They did a study years ago where they had cameras and tape recorders, and they just listened to what was going on in the doctor-patient encounter in primary care. And the doctors knew that they were being recorded. You would have thought they would be on their best behavior. 18 seconds was all it took before the physician started jumping in with our very directed, very specific questions. Doctor-patient communication is very important, very hard. In addition to learning how to listen, I think we physicians have a lot of other things to learn about. This evening, we're going to divide our first presentation into two parts. I'm going to deal with what I would call the technical part of communication. How to gather information, make certain you understand it so that you can make an informed decision. Then I'm going to turn things over to Dr. Bach to talk about how we actually work with students and work to improve the quality of our communication. The reason we chose this topic is because of the following scientific data. Numerous articles have shown consistently a very positive association between the patient reporting a very good quality communication with a doctor and better satisfaction, less medical malpractice cases, on down to improved pain control, even better blood pressure and glucose control. Now, the quality of the doctor-patient communication involves dealing with statistics. So let's start with our next audience response question. And my question is, What does a 30% chance of rain tomorrow mean? A, it will rain during 30% of the day. B, it will rain over 30% of the area. C, there is a 3 in 10 chance of seeing measurable rain in the area. And D, 3 meteorologists think it will rain, 7 don't. So go ahead and enter your response. C, this is a great class. All right, very educated, but can I tell you they asked the same question in Germany, and in Germany, I don't know, the different communication, but they thought it meant it will rain during 30% of the day. When they ask this question in New York and in Seattle, people get it right. Indeed, there's a 3 in 10 chance of measurable precipitation. All right, so for this first part of the presentation on informed decision making, I want to review the theme that I call collective statistical illiteracy. I use the word collective because it's not just patients. I'm going to walk through examples of patients having challenges dealing with numbers and statistics, but then I want to move to examples of physicians, examples of healthcare administrators that are making major decisions, and the mass media and how they influence our healthcare. So let's start with patients. I love being a clinician because of the diversity of my patient population, and it's really an honor and a pleasure. And I think this first slide shows how much patients vary. A survey was sent to adult patients in the US and asked them, do you prefer to leave decisions about your medical care up to your doctor? Look at the variation in responses. On the left, you'll see that quite a few agreed. They strongly agreed, moderately agreed. These are the kind of patients that will say, well, what do you recommend, doc? Or they'll ask me, if I was your mother, what would you recommend? And we as clinicians need to make certain that we're listening to these patients and that we get a good sense of their values and their emotions so that we can help guide them to the decision that's right for them. Now, what about the people that answered on the far right of this slide? They disagreed. They want to be in the driver's seat. They want to make these decisions. We need to make certain that they have the information that is required and that they understand it. Let's talk about numeric literacy, or perhaps I should say illiteracy. A survey was sent to adults in the New England area, and they asked them questions, and the first one was the hardest. They asked them, how do you convert 1 in 1,000 to a percentage? On the far right, I show you the results of how many got this answer correct on the survey. 1 out of 4. And you'll see that those with a high school diploma or less, 23%, and those that had a college degree didn't fare any better. Let me move on to the next audience response question. And this moves from sort of numeric questions about percentages to more of a medical context and personalizing it. Pretend that you're a 41-year-old woman, and I will ask you, what do you think your risk is of a diagnosis of breast cancer in the next 5 years? And I've given you answers here ranging from A, less than 4%, to 10%, 20%, and 50%. So let me have you enter in what you think a 41-year-old woman's risk. And this question gets at what is our perception of our risk of disease? This is interesting. I actually asked this question 3 years ago in mini medical school, and I think some of you may have remembered. The correct answer is A, less than 4%. Some of you are, nodding. Yes, you got it right. Most people have a heightened sense of our own risk of disease. We read about them on the web. There's a growing amount of information out there. I've heard the new term, instead of hypochondriac, cyberchondriac, because there's so much data out there. And as you can see, it's hard to know, well, what is our risk of disease? Let me move now from discussing patients, though, to discussing physicians, because it's not just patients in this general audience that many of you may have gotten this answer wrong. I asked the same question of physicians, and I asked this of physicians that actually work in breast imaging. So every day they deal with women, and they should know what a woman's risk of breast cancer diagnosis in the next 5 years is. This shows you 140 radiologist responses. Each dot is their answer on this survey. I even underlined 5 years, so they didn't think I was asking about lifetime. They were all over the place. And I add a line in here to show you the calculated risk. This line is very low. Remember, 3.4% is the actual estimated risk of a 41-year-old woman. 96% of the radiologists who work every day in breast imaging overestimated a woman's risk. of breast cancer. So how are we doing on informed decision-making as physicians? I am thrilled to be able to share with you some new data that is the first of its kind. It's a nationally representative survey of over 2,500 adults in the US. It's currently in press at this journal called Medical Decision Making. Some of the results are also available on a website for the foundation that supported this research. It's the Foundation for Informed Medical Decision Making. They asked these adults to describe their interactions with doctors in the preceding 2 years. And they asked about their experience with orthopedic surgeons and how they communicated with them about back surgery and knee surgery. They asked about interactions with doctors about taking medications and also cancer screening. There were 3 questions that I've shown here that I think would be important to share with you the results. Let's start with the first, which is, did the clinicians actually make specific recommendations? And the answer is yes. Just like Nike, just do it. For surgery, the orthopedic surgeons, 65% of the time, the patient's perception was that the orthopedic surgeon said, I recommend you have this operation. Among medications that were discussed with patients, 90% of the time. And for cancer screening, the patient said, oh yes, the doctor recommended I have the screening. If we are making these strong recommendations to patients, I hope that we are discussing the benefits and risks. So let me show you the answer to the next survey question, which is, what percentage of times did the patient report that the doctor actually shared with them information on the benefits and risks? Around 50% of the time. Now let me add in data on the far right. Did they discuss the risks? Everything we do has side effects. Nothing is without risks. Now the final survey question I think gets at the heart of informed decision making, which is, were patients actually asked for their opinions? The surgeons did fairly well. Half of the time they asked the patient, what do you think about having this operation on your back or on your knee? For medications, and this may be medications that we're recommending patients start that they'll have to be on for the rest of their life. 1 out of 3 patients said, yes, the doctor did ask for my opinion. For cancer screening, less than 1 out of 5. Now, with cancer screening, there is a lot of controversy on some of the cancer screening. You all read the newspaper. You know the new guidelines for mammography for women in the 40s. We have uncertainty in a lot of what we do in medicine. And we have false positives on tests. We have false negatives. And I think we as clinicians sometimes are uncomfortable acknowledging uncertainty in medicine. I want to share with you specific quotes from physicians that are having a hard time acknowledging uncertainty in medicine. This was a study that was done in Germany, and I think that this shows that Ben Franklin had it right. He said, in this world, nothing can be said to be certain except death and taxes. And I think that this study really highlights how there is nothing that's 100% certain, and there is no zero risk, but only risks that are more or less acceptable. This was done in Germany. They had what I call an undercover client. This was an actor who actually showed up at 20 different health clinics in Germany, and he was a male, and he said, I'd like to be tested for HIV. He had no risk factors for HIV, and he asked the physicians, could I possibly test positive for HIV if I don't have the virus? Now, I will let you know that there are, and this is rare, false positive HIV tests. And because of this, we now have added in sequential testing so that we often do 2 tests so that we can lower the false positive rate. But indeed, there are false positives. There's also false negatives. So let me share with you the responses of the physicians. One said, no, certainly not. A second said, absolutely impossible. A third said, well, the specificity is 99.9%, and I doubt patients understood that. One said, don't worry, trust me. And I actually liked this last one. No, only in France, not here. Now, I actually think geography may have something to do with our medical destiny and the medical care we receive. In the US, we have noted variation. You see here potential variation in medical care between Germany and France. There is an extensive amount of variation in the medical care that is received in the US. Let me just give you 2 examples. In the state of Vermont, at one point, 8% of children in one area had their tonsils removed. versus 70% in another area. In Iowa, at one point, the proportion of men who had prostate surgery varied between 15% and more than 60%. Is something different in the water? I don't think their bodies are different. I think that the mystery here lies not in the lakes and streams, but behind that door and what's going on in the doctor-patient encounter. I want to move to the third group, which is the administrators who are helping to decide the direction of medical care, because I also think that some of this variation in medical care is being guided by administrators. So for this section, I have an audience response question, and I want to ask you to think through, if you had $20 million and we put you in charge of buying a new screening program, a cancer screening program for King County for 2011, which cancer screening program would you support? And I want you to vote for it using your clickers. A program that reduces death rate by 34% compared with no screening program. B, one that produces an absolute reduction in deaths of cancer by 0.06%. And the final program is one that prevents one death for every 1,588 patients screened over 10 years. So as a group, I want you to think through, you're sitting on the administration board, you get to make the decisions, you're having 3 different groups that are coming with you with their reports and their statistics. Which one of these would you support? And this shows the voting results. 61% of you in the audience actually said that you would spend your $20 million on a program that reduces the death rate by 34% compared with no screening. Well, let me share with you the news. A, B, and C are the results of a single published clinical trial in Sweden. One result is just how you describe the results. A is what we call the relative risk reduction. It sounds like a lot. Pharmaceutical industry uses this type of numeric information frequently. B is the absolute risk difference, on a sort of how many patients will benefit. And C is the number needed to screen or the number needed to treat over a specific time period to actually help save one person. Section 4, the media. We really are influenced by the mass media. Let's start with celebrities. This is the Katie Couric effect. Miss Couric decided to have her screening colonoscopy live on the air, and I think she had the outcome that she wanted. People watched, and they thought about it, and they decided to go have their own colonoscopy. This shows the data for a 20-month period before her live on-air colonoscopy. This is from a very large Midwestern health plan. You can see it was pretty stable, the number of people in this health plan that had colonoscopies. Then T0 is the date that she went live on the air, letting everyone see her colon. And you'll notice that after that, in the Midwest, it shot up. There are other examples similar to this. When Nancy Reagan was diagnosed with breast cancer, the surgeons actually recommended a lumpectomy. She decided she wanted a mastectomy. The same week she made that decision, at a national level, you look at Medicare data and all those bills, there was an abrupt increase in the women that chose mastectomy, and it was a persistent increase. There were no scientific publications that week. There were no new guidelines on mastectomy. Nancy Reagan decided to have it. There was an abrupt change, and many other people decided to have it. I talked about the pharmaceutical industry. This is an example of an ad for a drug called Lipitor, and this is, it says stroke, and I think this is a zipper, but it's hard to tell. They're sort of breaking apart the stroke, and they say Lipitor cuts the risk by nearly half. And then in the fine print, they say Lipitor reduced the risk of stroke by 48%. If you look at the randomized clinical trial that this information is based on, it lasted 4 years, and half of the patients were given a placebo, a sugar pill, the other half were given Lipitor. At the end of 4 years, in the placebo group, 2.8% of the patients had a stroke. On the Lipitor group, 1.5%. So 2.8% down to 1.5%, that almost cut it in half. Sounds different, doesn't it, though, when you think about it that way? Now, this issue of relative risk, absolute risk is so important that I actually want to go through an example. And I'm going to go through it in detail here. I want to show you how you can have a relative risk reduction of 50%. Depending upon how common the disease is, you can help a lot of patients with your medication, or you can help a few. Let me walk through scenario 1. On the far right-hand side, I have 100 bodies. Say you have 100 patients, and you're going to follow them over for a year or two. 60% of them, shown here in yellow, will have no risk of disease at the end of your study period. 40%, shown here in pink at the bottom, are at risk to have the disease. If you take this 100 patients and put them all on your study medication, and you note a 50% relative risk reduction, this shows you in green how many would benefit. 20 patients. Now, let me show you scenario 2, where instead of 40% of people at the end of a year, it's only 4%. And I want to say that I don't know too many diseases that in a one-year time period, 40% of the people will get the disease, maybe the common cold. Most of the rates of our diseases are very low. They're less than 4%. So let me walk you through, though, if the rate of disease in scenario 2 was 4%, you would see in yellow, 96% of these people, with or without the treatment, they wouldn't have any problem at the end of the study period. And the bottom 4 figures in the bottom right, if there's a 50% relative risk reduction with the medication, 2 patients benefit. Now, if this is a serious medical problem and you're one of those 2 patients, that's important. But remember, everything we do can have potential risks. And so we hope that the other 98 patients that took the medication that didn't benefit, we hope that they didn't have untoward side effects. My final example brings together the whole concept of collective statistical illiteracy. Remember, I used the word collective because it's not just patients, it's the physicians, it's the health administrators, it's the media. This is an example of how collective statistical illiteracy can lead to untoward and unwanted side effects. In 1995, in England and Wales, the 3rd generation of the birth control pill was being used. They had a safety medication monitoring committee, and they noted that this 3rd generation pill had a 100% increased risk of thrombosis or blood clots that can be potentially life-threatening in the legs and goes up to the lungs. And they thought, gee, 100% increase in risk of thrombosis compared to the older 2nd generation pills. We need to do something about this. They immediately wrote Dear Doctor letters and sent them out to 190,000 general practitioners. They sent certified letters to all of the pharmacists, to all of the health plans. Then they decided that they needed to have emergency broadcasts and let the patients know. This led to anxiety. A lot of women stopped the pill. A lot of physicians stopped prescribing. And over the next year, the number of pregnancies definitely increased. This next figure shows you another outcome. This shows the abortion rates in England and Wales over time, starting from 1990 to 1995. You'll see a downward trend. At the time of the pill scare, this downward trend was reversed. Now, let me explain what a 100% increase in thrombosis actually was. I've set the stage, I've shown you the outcome. For this older 2nd generation pill, 1 woman out of 7,000 would have a blood clot. For the new generation, 3rd generation pill, 2 women out of 7,000 would have a blood clot. Going from 1 per 7,000 to 2 per 7,000 is a 100% increase. We need to be very careful in how we interpret numbers and statistics. So in summary, for part 1, there is a technical aspect to what we do, and it deals with discussing the benefits and the risks with our patients. I think that patients really need to understand their choices, and sometimes the choice can be to forego treatment. Perhaps the greatest untapped resource in American medicine is the patient themselves. We need to help make certain that we're providing information to them and that they understand the information. I'd like to now turn things over to Dr. Bach, who's going to talk about helping us get to understand patients' values and how we educate medical students. We're going to take questions at the end, okay? Thank you.
Thank you. What I hear from patients and family members dealing with an experience with the medical system is that it all goes by in a blur. And what I'm going to focus on is a different aspect of the kinds of factors that influence communication. And my big point here for the first part of my talk is that that emotion has a huge influence on difficult conversations. You know, what patients tell me in studies is that getting bad news is the nightmare scenario. But what I also see in studies is that there are other aspects where patients don't get the information, don't believe it, avoid it, or don't act on the information because it gets presented in a way that's difficult for them to process. On the other side, you know, these difficult conversations occur in this whole sea of emotion, and it affects doctors too. Doctors are hesitant to be frank. They don't manage the emotional content of the conversation and feel unclear about their role. And I'm going to give you a couple of examples of this from some of the studies that we and other people have done. So it's the nightmare scenario, and the specter of death, I think, is lurking in the background for many of these people, and that's one of the things that makes these so powerful. So here's an example from a study we did at the Hutch. We were interviewing patients who were coming for a discussion about treatment for a blood cancer, and this was a 38-year-old man with a kind of leukemia. Before he went into his visit, we asked him, what do you think your chances of being cured are if you have a transplant? And he said 90 to 100%. Well, when we audiotaped the conversation that he had with the doctor, here's what the doctor said. So if you have 100 people, this gets to our numerical illiteracy thing, the survival curve drops down because people die of one thing or another, including relapse. That tends to level off at about 2.5 years after transplant and stays level after that. It's about 30% in your situation. And when we asked the doctor after the visit what was his estimate of the patient being cured, he said 30%. So you know, this guy, the doctor, is trying to be completely frank. He is telling the patient the exact truth. And this is the graph from the medical study that he's talking about, and this person was in this risk group at the bottom level here, and here's where he got the 30% from. So he's being totally accurate, which is not always the case. What did the patient hear? Well, when we called the patient 2 weeks later to say, you know, what did you take away from this visit? And we had this audio tape, here's what he said. After the doctor, said the 30%, he just kept dinging along in his facts, and I was stunned. Literally, my note-taking was completely done. All I wrote was 30% the rest of the time all over my paper. And I mean, I just couldn't get past that point. I don't know how to describe it. Now, that's 2 weeks later. The really powerful point of this is that immediately after the visit, he saw the research assistant again on the way out from his visit, and the research assistant asked him to fill out the questionnaire again about what did he think his chance of being cured were, and he said 90 to 100%. So what happened here was kind of an emotional hijacking. The emotion of the visit completely blocked his ability to take the information in. And the thing that worries me is that when this doesn't get recognized or managed during the visit, you wonder about the quality of decision making that can occur if that's the issue, if he's that overwhelmed. I mean, they had a friend with him who said it was like, you know, getting gravel from getting a delivery of gravel. It's like starting to come out and you're going, no, no, not there. I wanted it somewhere else, and it just keeps coming. It's too late. It's a stunning thing. Now, on the other side, I talked about what happens with the doctor. You know, if the doctor's uncomfortable, does that translate to less discussion? Well, I mean, there are certainly a lot of anecdotes that say yes, and this is a quote from a study of mine with a patient who was talking about her oncologist of a number of years. If I discuss anything about dying, he becomes uncomfortable, so I changed the topic to baseball. I mean, this patient, and I think this is not that unusual, is so sensitive to whether the doctor is still engaged with her, that she's willing to completely walk away from a topic she's really worried about so that the doctor will stay with her and won't look too uncomfortable. So there aren't a lot of studies addressing this, but there is this really interesting little study with Greek medical students. So of course, you know, these are not doctors, but of course we're in mini medical school here. And what they had these medical students do was go into a room to give a patient actor bad news that they had cancer, and they rated their positive affect, you can see here on the left, when they got the instructions, right before they went into the room, and after they came out of the room. And what happened, you can see in this blue line, is if they had to give the bad news and give it truthfully, their positive affect went down, and it stayed down, right over here. If I can find my arrow. The blue dotted line. If the students were instructed to conceal the bad news, it's that gray dotted line. Their positive affect went down and then it went back up, because actually if you don't give the bad news, it's not so bad. For the doctor, anyway. And what I think this shows is, basically, if you're not really trained about how to communicate and how to deal with all this, it's easier to lie. And I don't think people do that intentionally, but I think that's one of the unintended consequences of these complicated issues. So here's my audience response. I told you I had PTSD, so I only have 2 of these as opposed to 4. But here's my question. How often do oncologists respond to emotions verbally? So this was a study of oncologists talking to patients with advanced cancer. How often did the oncologist comment on the emotion or acknowledge them or recognize them or anything like that? A. And you know what? It turns out the A people are right. It was 11% of visits. This is for the whole visit. This is one empathic comment in the whole visit. And in this study, this is the largest audiotape study of oncologists that's ever been done anywhere, and it was done in the United States. It's 11% of visits. And here's the actual slide with the data, if I can. So here, 51 oncologists, 270 patients, 400 visits. To get credit for doing something empathic, you could actually make a sympathetic grunt, and they would have counted that. And so the issue is, you know, it's not as often as you would expect. It's a little disappointing, because the poor communication and failure to acknowledge the emotional dimension of this has consequences. There's less trust, there's less satisfaction for the patient, there's less satisfaction for physician. But even more than that, there's some real medical outcomes that happen. If you don't talk about awkward, difficult conversations, and patients who did not have a conversation about, quote, the kind of care you'd want to have had at the end of life, were in one large national study, they were more likely to die in an intensive care unit after an attempt at CPR that was unsuccessful or on a mechanical ventilator. Their families who were left behind were more likely to be depressed, have regrets, and have lower quality of life. So this is an instance where the communication doesn't affect just the patient, it affects the entire community of people who are connected to that patient. And so that's why we as physicians have a responsibility to manage this, not only for the patient, but for the families who come with them. What's wanted, and this is in a study that we've done just recently, where we've done one of the first studies where we have patients listen to audio tapes of doctors talking to patients. And what these patients tell us is they want a complicated combination. They want some empathy and some guidance. They don't want just one, they don't want just the other. So here's one of our subjects. He said, he was commenting on what the doctor was doing kind of approvingly. The doctor has to let him, the patient, let his emotions run a little bit. Personally, I would say, and this is a person who's had cancer and been treated, he said, I would say, son of a bitch, now what do we do? So that's what he wants right there. He wants that little moment of recognition that this is a tough moment, and he wants the doctor to say, hey, here's the next step. So it's this combination. The group of patients that we have interviewed for this study is very concerned about how the doctor frames the issue. They don't want the doctor to talk about it being too scary just for the sake of scary, because that can make it worse. And patients are very concerned about being told how they feel. So for a doctor to go in and assume that a patient is feeling scared, feeling anxious, that actually isn't a good thing. That actually makes people feel distanced from where they are, and it doesn't really improve the communication. So the conclusion here is that acknowledging emotion is really critical, but you need expertise and you have to provide guidance to the patient as well as empathy. So, the other big downside of failing to acknowledge the emotion is what happens at the end of life in a doctor-patient relationship. Patients worry about being abandoned, and when we did a large interview study of patients, physicians, families, and nurses in the Puget Sound about patients with advanced cancer and patients with advanced lung disease, you know, what happened was the interviewers came back and started to tell me that they were hearing patients talk about being worried about abandonment at the end of life. And I said, oh, these doctors are not going to abandon them. And the nurse researcher on the study looked at me and said, you know, I don't think they'd be worried about this unless they had really had some experience of it. And it turns out the nurse was right. So here's what some of the patients said before death. I think it's important that you still have contact with them, even though there might not be anything they can do to make you better. Another patient said, I need to be able to depend on my doctor. If I call you next week, will you see me right away? And then later, after death, this is from a spouse who went to see the doctor with her husband. The doctor recommended hospice and then never called them again. She said, I realize the doctor's busy, but he knew her husband and I. We were together through the whole thing. It would have been nice to hear from him. She said not getting a call from the doctor was like a slap in the face. And this was somebody that she was very attached to. The oncologist, in a parallel way, was gone the week the patient died and came back, and in his interview, he said, I thought, well, I should really call B, the wife, and then didn't because I was just too busy. And then I felt guilty that I hadn't called her earlier, and I didn't know if it was appropriate. Maybe it would just stir up emotional stuff. So the poignant thing is that, you know, the spouse was waiting for a call. The doctor was worried he was going to do some damage, and it turned out all they needed was a little moment of connection just to acknowledge the magnitude of what they had both been through. And you know, for doctors to be able to stand in, make that call and do that, it requires a certain amount of mentoring, guidance, and character. So here's a question for you. Can you teach this? So can you teach a physician to improve their communication? So let's take one example about asking an explore question. If before some training, 28% of patients could do an open-ended question about how you're doing, what do you predict after the training? 35%? Can they improve to 35%? 55%? 75%? I didn't even give you a negative value, but maybe I should have done that. Okay, we're kind of across the board here. That's kind of interesting. Well, it turns out in the study that we did, training young oncologists, actually the answer was 75%. Like you could increase their ability to do that from 28% in an encounter to 75%. And you know, that's the kind of level that could really change the texture of what a visit is like. So now I'm going to try and keep. So you learn communication skills, but not the way they are usually taught. I mean, the time-honored method has been osmosis. We put you in this, you know, big vat of hospital, clinic, etc., and it just happens automatically. But the reality is, lectures, didactic presentations, the usual way, pretty ineffective. It turns out the data shows that what you need is a small group learning situation and feedback on your performance as it happens. Written feedback about how you're doing, like in this study that was done in the UK, one of the largest studies of communication skills that's ever been done. Senior oncologists, they got randomized to either a small group course for a long weekend or detailed written feedback on videotapes of themselves in clinic. And it turns out you need that feedback in the moment because written feedback later, even if it's you in clinic, had zero effect. But if you went to the small group learning, got the feedback, worked, in this case with actors, they had very significant improvements in empathy, open questions, responses to patient cues that persisted for 12 months, which in the education, in the education world, that's like a home run. Because a lot of the stuff that you're learning, it seeps away really quickly. So I think the issue here is that learning these kinds of skills sets up a kind of positive feedback loop where people go, patients respond to them in a different way, that gives them a kind of interest in their practice, and it's positive feedback that happens in the moment. how much does this take? Because, doctors are always telling me, well, I don't have enough time. It takes too long to be empathic. Well, here's a study where women with breast cancer or no breast cancer looked at one of two videos. They were exactly the same. A doctor talking to a woman about her recently diagnosed breast cancer, and one video is 40 seconds longer. And in the 40 seconds, the doctor says stuff like, I know this is a lot of information. Stop me if you have any questions. It's nice, but it's not like he's Dr. Welby. He's not like the Dalai Lama. He's not charismatic or anything like that. And yet, even in this 40 extra seconds, they asked people how anxious they were right after they saw the video, and the women who saw the video with the empathy were significantly less anxious. So in fact, some of these things just take a few minutes. So there is a better model learning. We've done a lot of work with this, and in fact, one of the studies that's going on at UW-Medicine now is a large study of internal medicine residents that's randomizing them to a small group conference versus kind of usual learning. And actually, we are surveying patients, families, and nurses to see what they think about these residents' communication. So we're trying to take them from being experts to people who can guide patients. And what does it sound like? Here's an example. The patient says in one of our studies, isn't there anything more you can do? And before the conference, the doctor says, you've had a lot of chemotherapy, haven't you? Which in our business, we would call a distancing response. We would call that not empathic. Afterwards, the doctor, seeing a different patient in a different scenario who says exactly the same line, says, there are more things we can do. This has been a roller coaster ride for you, hasn't it? That's a huge difference in the tone of a conversation that, in this doctor's words, made her feel less flustered, words less tangled. I can focus on the person across from me, she wrote, and find out what they need in that moment, and that seems like progress. And I would say that is indeed progress. And we've tried to summarize some of this stuff in a book. And what I'm going to say in the end here is, how can we build better communicators? Because that's one of the things that I think we're trying to do, not just in medical school, but in the School of Medicine as a whole, where there have been some huge educational innovations led by Erica Goldstein to try and build a small group learning experience that helps scaffold this kind of skill as a key skill for doctors. Because nowadays, it's not enough just to know the expertise. You have to know how to match that medical expertise up to an individual patient and to be able to draw on the kind of numerical literacy that Dr. Elmore was talking about. But to do that, you need to appreciate the role of emotion, you need skill training, you need to see emotional intelligence as a critical attribute of what physicians do. And so with that, I think we have time for a few questions.
Thank you so much.
So should we just, Yes, sir.
My question is generated by the introductory remarks. A recent article in the New Yorker talked about the cost of health care. And it said, pretty much, gave what they thought were the causes. But during the article, they said that 3 places in the United States had a very good record for maintaining health care. I think one was Chapel Hill, the other was the Mayo Clinic, and the last was Seattle. And my question is, what has been the role of the University of Washington in keeping healthcare costs down, and have there been other big players in this area that have contributed?
Thank you. That is a great question. Basically, you cited a recent New Yorker article that described amazing variability in what is spent per capita, per patient. There are some places it's $15,000 per year per patient, others it's $6,000. And these are, same demographics. At the University of Washington, I think it all starts with education and the mindset that we want to practice evidence-based medicine. And part of evidence-based medicine, you have to realize that sometimes more isn't always better. Sometimes watchful waiting is an appropriate approach. Sometimes we shouldn't get that MRI scan, and we should use our clinical acumen and really listen to the patient, take a very thorough clinical history, and do a good clinical examination. Tony, what are your comments?
I was just going to say that, that one of the things the University of Washington has led in is health services research, which is really the branch of research that does the kind of comparative effectiveness studies that everyone is talking about right now. And I think that awareness really has seeped through the medical school and seeped through the community, actually.
Good evening. Thanks for taking the time to come out. It's really great to kind of let the public in, so I'm appreciative of that. I think this would be primarily directed at Dr. Elmore. Thank you for kind of talking about trying to understand the statistics. I mean, everybody's overwhelmed with lots of information. But one of the things that has occurred to me as I've been looking at this is wondering why there isn't more of an emphasis on talking specifically about number needed to treat and number needed to harm in the context of reporting results. Because that seems to me to be something that is, for vaccine, number needed to treat is 1. For Lipitor, number needed to treat is what, 1,000? So if that's a metric that we start using and people start to understand what it means, perhaps we could get to the point of being able to have people be more informed about those things. And I'm wondering, I guess the question is that, do you see that as a trend? Is that something that you see happening, or I'm interested in your thoughts about it?
The question had to do with, remember the difference between relative risk reduction, absolute risk reduction, and then there's that other way of describing the benefits and the risks, which is the number needed to treat over maybe a 10-year period to help 1 or 2 patients. It's interesting how we're still not using that descriptive terminology often enough in medicine. They've done studies of the major scientific journals, and sadly, they've found that in the results section, they are more likely to describe relative risk reductions for the benefits, and then they use absolute risks when they describe the risks, so it sounds less. I mean, even the journals are doing it. There have been a few scientific studies where they're investigating press releases from the scientific journals, and they're investigating the quality of them, and they're trying to standardize them. And in fact, some investigators from Dartmouth have come up with a very simple table that they think should be available for every article that's published and every medication, similar to the FDA food labels. What are the risks, how many patients, number needed to treat. It's a novel idea. We should be able to do that so that we have the information that can be given directly to the patients. On our handout, we also note what I think is a really interesting website called healthnews.org. This is a member of the media who rates publications, New York Times, WebMD, and he rates the quality, he and 2 other reviewers rate the quality of what is out there in the literature. And I find that very educational to learn from how they're reviewing the mass media. So I think we're trying to use number needed to treat and number needed to screen, but we have a long way to go.
But so you don't see it as a big trend happening anytime soon, I guess is what I'm asking.
Well, it's all about what the story is, and I think part of it is for people like you to demand better information from the media.
Right.
So I think we all have a role.
Thank you. Thank you.